Hey, my TBL is tomorrow and I haven't even started yet. I need to look up nifedipine, but I don't know where. YouTube.
What exactly is nifedipine used to treat? Mainly it is used to treat hypertension, angina and Raynaud's disease. What exactly is angina? Angina is chest pain caused when the blood flow is reduced to the heart, causing ischemia. The most common type is stable angina. It becomes a problem when stenosis occurs in the vessels due to a buildup of fatty deposits causing the artery to narrow. This is known as atherosclerosis. During rest, just enough blood can flow. However, when the body demands more oxygen, like during exercise, the heart needs more blood. During periods of exercise and stress, chest pain can occur as the blood supply isn't meeting the metabolic demands of the heart. Chest pain can also be caused if the myocardium wall is thicker and therefore requires more oxygen. The pain usually disappears with rest. The chest pain is a squeezing sensation and can travel through the left arm, jaw, shoulders and back. The pain usually lasts 20 minutes and disappears after the exertion is removed. Unstable angina is when chest pain occurs during exercise as well as during rest. It usually is caused by a rupture of plaque with thrombosis, meaning a blood clot forms on top of the plaque. Only a limited amount of blood can flow, causing the heart tissue to feel starved for oxygen even while pumping at a normal rate. Old age, smoking, obesity, and eating a diet high in saturated fats all increase your risk of angina. Nifedipine is also used to treat hypertension. High blood pressure can cause damage to the endothelial cells that line the blood vessels. In the long term, complications such as strokes, aneurysms, and myocardial infarctions can occur. Most of the time, hypertension happens without an underlying problem, and this is primary hypertension. Risk factors include old age, smoking, obesity, and salt intake. Secondary hypertension has a specific underlying cause. Anything that limits the blood flow to the kidneys can cause hypertension, for example atherosclerosis. Reduced blood flow can cause the kidneys to secrete renin, which leads to water retention. A greater volume of fluid leads to hypertension. Finally, nifedipine is used to treat Raynaud's syndrome. Temporary spasm of vessels block the blood supply to the fingers and toes. They become white due to a lack of blood flow, followed by blue as the vessels dilate, and red as the blood begins to return. It is triggered by cold temperatures, anxiety, and stress.
So nifedipine is used to treat hypertension, angina, and Raynaud's, but how was it discovered?
Well, the discovery of nifedipine was started in the year 1882. This is when the essential role of calcium ions for cardiac contraction were clarified. The discovery was purely accidental. 1950. There was a high incidence of heart attacks, which caused an increase in the research of cardiovascular agents by Bayer Pharmaceuticals. Dr. Vater had a vision to supply the diseased heart with more oxygen using drugs to dilate the coronary arteries. He introduced the technique of measuring the oxygen content in the coronary sinus. Carbochromin and dipyridamole were known to dilate coronary arteries, and these were used as reference compounds in his experiments. Dr. Buzzard was looking at the natural product kellen, which is the active constituent from the seeds of Mediterranean plant Amivisnaga. In Egypt, the plant was used as a natural antispasmodic for renal colic symptoms and a diuretic. Both scientists subjected kellen to a structural variation process that lasted several years and led to the discovery of nifedipine. The analogues synthesized by Buzzard, including the chromone, were tested using Vater's experiment. The aim of the experiment was to find molecules that could be given orally to increase the oxygen content in the coronary sinus. Those that increased oxygen content only worked when administered intravenously. This was due to the analogues being metabolized by the enteral enzymes before reaching their site of action. To increase the resistance to these enzymes, Buzzard performed a modification of the quinolone basic structure. The aromatic residue was reintroduced after being removed from the quinolone in another position. 1964. The first compound, BS1861, was given to dogs. Using femoral catheterization, Dr. Vater measured the increase of oxygen saturation in the coronary sinus of the dogs. Hundreds of derivatives were synthesized and tested to find the right compound. Nifedipine was one of the 350 selected dihydropyridine analogues, which produced a potent and advantageous effect on the coronary blood flow that drew their attention. It showed rapid and long-lasting effect when administered orally or sublingually. 1970, clinical trials in European and Japanese hospitals were successful. Nifedipine reduced the incidence of angina attacks, and this activity was attributed to the drug's vasodilating activity. 1975, the drug was marketed under the brand name Procardia in the US, which was a great success. Bayer markets the drug as Adalat. 1995, nifedipine was found to increase the mortality rate in patients with coronary artery disease. This is caused by short-acting nifedipine, which cause reflex tachycardia. Because of this, only sustained-release preparations of nifedipine are recommended.
Wow, it was used in ancient Egypt. I wonder how it's made on an industrial scale. What does it even look like?
The structure of nifedipine. By applying Lipinski's rule, we can determine if it is orally available. It has a molecular weight of 364.34, which is less than 500, a log p-value of 2.2, which is less than 5, 1 hydrogen bond donor, 7 hydrogen bond acceptors, and has 5 rotatable bonds, which increases its bioavailability, and therefore it is orally available. This is a dihydropyridine. This is similar to a pyridine, but is semi-saturated with 2 substituents, replacing one of the double bonds. The N1 in this aromatic ring is essential for activity. In the ortho positions are 2 methyl groups, which increases hydrophobicity and potency. In the meta positions are 2 ester groups, which optimizes activity. It also makes the molecule more prone to degradation. They also take part in hydrogen bonding as hydrogen bond acceptors. In the para position is a nitrophenyl functional group. The nitro group is in the ortho position. A substituted phenyl ring at the C4 position optimizes activity. The ortho substitution on nifedipine provides sufficient bulk to lock the conformation so that the aromatic ring is perpendicular to the dihydropyridine. This conformation is essential for dihydropyridine activity. Amlodipine is a calcium channel blocker and has enhanced potency. A dihydropyridine can tolerate larger substituents as amlodipine has larger substituents on C2 and C6.
Nifedipine is synthesized by a Hansen condensation reaction. It can either be done as a single-step synthesis or as a two-step synthesis, but the yield of nifedipine is much larger with the two-step synthesis. First, a mixture of orthonitropentylaldehyde and ethyl acetoacetate are dissolved in a solvent such as ethanol. The mixture is heated under reflux with ammonia, and an aldyl condensation reaction takes place, forming a benzyl iodine derivative. When a second mole of ethyl acetoacetate is added, microaddition occurs, and a 1,5-diketone compound is formed. A reaction of the 2 carbonyl groups with ammonia forms a dihydropyridine ring, and hence nifedipine is produced.
I wonder what nifedipine actually targets in my body.
How does nifedipine work? Blood vessels in our body are lined with cells containing L-type calcium channels. Calcium ions entering the cell through these channels bind to calmodulin. Calcium-bound calmodulin then binds to and activates myosin light chain kinase, MLCK. Activated MLCK catalyzes the phosphorylation of MLC, short for myosin light chains, in the presence of ATP. MLC phosphorylation leads to cross-bridge formation between the myosin head and actin filament, and hence smooth muscle contraction, reducing diameter of blood vessel and increasing blood pressure. However, if we rewind, this is when nifedipine comes in. Nifedipine is a calcium channel blocker. Despite its name, it does not physically block the channel. Instead, it binds to specific receptor sites located within the central alpha-1 subunit of L-type potential-dependent channels, acting as an antagonist, inhibiting the initial influx of calcium. This prevents the chain reaction that followed from happening, and instead causing dilation of the coronary and systemic arteries, increasing oxygen delivery to the myocardial tissue. The vasodilatory effects of nifedipine results in an overall decrease in blood pressure.
Nifedipine has both on-target and off-target effects. The specific mode of action is at the target L-type calcium channels. However, it also has some significant on-target secondary effects, with research looking into possible off-target effects. There are 2 vital secondary on-target effects that I will cover in this video. According to the British National Formulary, short-acting formulations of nifedipine can cause reflex tachycardia, and as a result of this and other factors, it is no longer recommended for the treatment of hypertension. Reflex tachycardia is an abnormally rapid heart rate caused by autonomic nervous system effects. A simplified mechanism of action for this effect starts with the on-target vasodilation of the arterial system. Vasodilation lowers the perfusion pressure in the aortic arch and carotid artery, where there are pressure receptors called baroreceptors. Decrease in pressure causes a decrease in the rate that the baroreceptors generate action potentials to the cardioregulatory center in the medulla oblongata. As a result of decreased stimulation from the baroreceptors, the cardioregulatory center decreases parasympathetic stimulation to the heart, which increases the heart rate. The cardioregulatory center also increases sympathetic stimulation to the heart, which increases heart rate and stroke volume. Contrary to this, the extended release formulation of nifedipine does not show the same reflex response, and therefore it is a safe antihypertensive drug. Another secondary on-target effect of nifedipine is oedema, which is caused by forces that drive fluid in and out of capillaries. The two net filtration pressures displayed in the diagram have been determined by calculating the difference between the hydrostatic pressure gradient and the oncotic pressure gradient. At the arteriolar end, the hydrostatic pressure exceeds oncotic pressure, meaning filtration takes place. At the venous end, the oncotic pressure is greater and absorption occurs. Now you may be wondering how this relates to oedema. In a normal system, there is an increase in pressure as the larger arteriole narrows into a smaller capillary. On taking nifedipine, the arteriole becomes dilated, causing a greater pressure difference since the blood moves from an even larger diameter vessel to a small capillary. This results in an increase in the capillary hydrostatic pressure at this junction and permits additional filtration into the interstitial compartment, resulting in edema.
Wow, everything I need to know all on one page. Thanks, YouTube.